Hello, and welcome to this presentation on intrauterine devices. My name is Bree Tristan, and I'll be discussing some background information on IUDs today, including demographics and some tips and techniques which we hope will contain pearls that help you to perfect your technique for relatively uncomplicated IUD insertions. You'll hear more about complicated insertions from my colleague Amna Dermish in our second presentation. I do not have any financial disclosures to share with you today. The objectives of this talk are to understand the changing demographics of IUD users and to review techniques for successful basic IUD insertions. We'll start with this graph, which is a snapshot of how American women's use of long-acting reversible contraception changed over the 10-year period from 2002 until 2012. As you can see, amongst women currently using contraception, 10.3% were relying on IUDs in 2012, and the numbers have been steadily increasing over time. During this same time period, we can see that IUD use among teens, represented by the blue line, remained relatively stable. The percentage of young women aged 20 to 24 who relied on IUDs, in red, increased rapidly during these 10 years. This is important information, as these younger women may represent a slightly more challenging population for IUD insertion. Now that we've spent a few moments discussing IUD use, let's talk about the actual process of IUD insertion. But first, a quick non-scientific view of real women's experiences with IUD insertion. As it turns out, as biased as it may be, the online data is not uniformly positive. That's why our goal is to help you to improve the IUD insertion experience of young women in your office. A good IUD insertion experience does start when we walk into the room. It's important to be open about the fact that this is not a painless procedure for most women, especially those who are nulliparous. However, it is something that she will likely tolerate very well with your support. Explain the steps, and be sure that she understands that some cramping is normal and expected during and after the procedure. Continue to provide reassurance by focusing on the positive. You can do this in many ways, such as reminding her that she's making a great decision. Continue to use the power of a positive perspective to put her at ease during the procedure as well, by giving her very specific guidance. A commonly used example is that instead of asking your patient to relax, you could guide her to let her back soften and her pelvis sink into the table. You could likewise breathe with her as she is encouraged to take deep breaths that relax the rest of her body. Next, of course, is the bimanual examination. This step is critical. You'll want to note how the cervix is positioned. Does it point skyward or toward the rectum? This will guide you in how you place the speculum and aid in visualizing the cervix. Note uterine size and position, including, of course, anti or retroversion or flexion, which will guide your sounding and the placement of your IUD. Good visualization is another critical ingredient to good IUD placement. As you prepare for the examination, be certain that the patient is positioned far enough down the bed and that you have adequate lighting in the room that you choose for IUD placement. In addition, when choosing a speculum for your patient, if given the choice, err on the side of a slightly shorter speculum. This will allow the cervix to be displaced slightly closer to you as opposed to farther away. There are also many patient factors that can impact your visualization, including body habitus, prior cesarean sections, cervical procedures such as LEEPs or cone biopsies. But using the information that you obtain in your history and from your bimanual, you should be able to compensate for most of these issues. Next, we'll consider tenaculum placement, a critical part of IUD insertion, which increases the efficiency and decreases the risk of perforation by aligning the uterus with the cervical canal. And remember, don't just place the tenaculum, use the tenaculum to provide the needed retraction during your procedure. This video illustrates how appropriate traction straightens the junction between the uterus and cervix, making it easier to place the relatively rigid IUD inserter all the way into the uterine cavity. When placing the tenaculum, pay close attention to the location of your tenaculum tips. You'll want to take a good bite, spaced about the size of a nickel apart. This will allow sufficient traction without causing unnecessary pain that comes with an overly large bite. Check after you've closed your tenaculum to be certain that you are not obstructing the cervical os. A good recommendation in order to decrease pain is to close the tenaculum slowly and to only clamp down to the first or second ratchet. And this is where the trouble usually starts, getting into the uterus. As we discussed, knowing and correcting for the uterine position is a key step of IUD placement. With a sharply flexed uterus, you can feel as though you're hitting a wall or need to turn a corner. Remember that traction on the tenaculum will align the uterine cavity and cervical canal. For anteflexed uteri, another helpful adjunct procedure is to provide gentle suprapubic pressure. Your MA can do this, as can the patient herself. For retroflexed uteri, you may want to consider placing the tenaculum on the posterior lip of the cervix, which can have the effect of straightening the canal more effectively in a posteriorly facing uterus. Next, it's time to sound the uterus. This will help us to better assess how easy it will be to pass the internal cervical os, as well as to determine the depth of the cavity. This can be performed with a rigid sound or something more flexible, such as an endometrial biopsy. To start, hold firm, steady, gentle pressure with your sound against the os while providing counter-traction from the tenaculum. If your sound is not going in, remember to feel very gently in the anterior and posterior directions in order to find the right angle. It's also an important time to remember to use sterile, non-touch technique. The tip of your instrument should not touch the vagina or any other surface before being introduced into the cervix. If you can't pass the internal cervical os, it's important to have a few other instruments available, such as os finders or dilators. How often are these needed and how big are IUD inserters? To answer that question, let's compare the sizes of different insertion tubes. They range in diameter from the smallest, with Scylla and Chilena, at 3.8 millimeter, to the largest, which is Liletta at 4.8 millimeters. An extra consideration with the Paragard, however, is that the folded IUD tip is actually slightly larger than the insertion tube itself. Its insertion width is actually 6.9 millimeters. If you have trouble passing the internal cervical os, one option is to use an os finder. These are small Teflon self-lubricating devices which are particularly helpful for negotiating the cervical os. They're highly flexible and good for finding the right track. These can be particularly useful in stenotic cervices. Of course, traditional dilators are also helpful in negotiating and expanding a stenotic cervix. Another favorite device for the office is the double-sided sound and dilator. This device has a 3 millimeter sounding end with a rounded tip and centimeter markings, as well as a gently tapered 5.5 millimeter dilator tip. Remember, cervical dilation is a safe addition to the IUD insertion process. Perforation is very unlikely if you know the uterine position and follow the cervical canal. Lastly, before you get started, remember to review the placement instructions for the device of your patient's choice. With more and more devices on the market, it's important to develop a familiarity with each of their insertion mechanisms. During your insertion, remember to either use sterile, non-touch technique, where your device doesn't touch anything except the patient's cervical and uterine canal, or to change into fresh gloves. Another tip to decrease insertional pain is to start by opening the device at least a centimeter shy of the uterine fundus, so that you only have to touch the fundus once after the arms have extended, as you nudge it very gently into place. So in summary, with IUD use increasing, refining your technique for successful IUD placement will be of great benefit to your practice. But if you've done everything we've discussed thus far, and placement is still not successful, what else can be done? We hope that you'll return for our second presentation on complicated insertions in order to learn more, and we look forward to seeing you at the annual clinical meeting.